Thanks, everybody. I'm sorry about that. There was a little pile-up on FDR, and so I think you know this much better than I do, but it reminds me of Route 9 in Boston, which becomes, coronary stenosis when something like that happens, not least for the drivers. Anyway, so on that note, it's my pleasure to join you this morning, and thank you so much, Suzanne, for taking first hit, as it were, if that's the right term, isn't it? That's a baseball term. But first hit on the mound. I'm going to follow up with something a little bit different, actually, and I want to thank very much Mona Lisa and the team from MedEd for bearing with me, because I'm going to talk to you about small molecules, because obviously you're going to hear beautifully in a minute from Ed about the breakthrough of monoclonal antibodies, but I just want to sort of put it in a hurrah that beyond antibodies and all that they're doing, there's a lot of exciting action in the small molecule space. Now, just to remind everyone about some key biology, I'm going to move through things fairly fast, but just to remind you about the complexity of biology in myeloma, and not least of which the mutational thrust that underlines it. This is whole genome sequencing that is 5,000 mutations strong at diagnosis, and at relapse after induction remission therapy, transplant and maintenance, this patient has over 12,000 mutations. We've obviously become very aware and cognizant of the impact of the genetics of myeloma and how they can be targeted. This seems an almost overwhelming task. Having said that, I hope to convince you that there are some small molecules, and in particular, some new targeted small molecules that hold real promise. Obviously, in that context, a multimodality approach to therapy is central. And this diagram from my colleague Giada Bianchi summarizes that beautifully. And the emphasis here is, with that kind of genetic complexity and microenvironmental complexity, obviously we need all hands on deck to do the job. And of course, we're very blessed because we have a number of approved agents that have provided us with a substantial armamentarium. But going forward, we obviously clearly need more. And in that spirit, there's some exciting stuff on the horizon. So what I want to dwell on today, and again, as Suzanne so kindly pointed out, we do have limited time. So by no means of being exclusive, I simply want to focus on a couple of small molecules that perhaps don't get the attention they deserve, perhaps, although I'd argue they're increasingly important, including Venetoclax, which I'm going to come to in a moment, Selinexor, a very novel alkylating agent that's actually targeted called Melflufen, and touch at the very end on next generation IMiDs and their impact, as well as the growing impact of pomalidomide. So just to re-emphasize the point about the genetics that underlie this disease, obviously with specific cytogenetic abnormalities, these in turn reflect profound genetic changes that can be very important. And I just want to bring your attention to the 1114 translocation and its relationship to NRAS, KRAS, and a variety of other downstream factors that may be very important, including opportunities for essentially biological overlap with molecules like IRF4. Why does this matter? Well, because we've been blessed with the advent of, I think, a very encouraging and exciting new development, which is the availability and study of Venetoclax in myeloma. Now, I'm sure many of you are very familiar with this oral agent, but certainly it's worth touching a little bit on the biology and recognizing that in myeloma, we've come to recognize that BCL2 is perhaps much more important than we originally thought a few years ago. I want to acknowledge especially my colleague Konstantin Mitsiadis, who over 15 years ago demonstrated that BCL2 was a major mediator of resistance to bortezomib. However, that area went quiet for a little while until the advent and the discovery really of the ability to target this area successfully with oral agents. Now, in particular, it's worth mentioning that sensitivity to Venetoclax correlates with high BCL2 expression, and of course, the issue of MCL1 expression is important because that's a pathway of resistance, but in turn can be overdriven by bortezomib. So with that in mind, the combination of a PI and Venetoclax obviously would be very fertile to study, and the preclinical data summarized here, which of course illustrates the critical point. And so essentially by inducing the expression of NOXA, which selectively induces degradation of MCL1, you can then potentially mitigate resistance to Venetoclax. And I would also remind you of the opposite, that by downregulating BCL2, you can restore sensitivity to bortezomib itself and, of course, other proteasome inhibitors. So what's the clinical data? Well, I want to quickly move through this in the interest of time, but suffice to say, I want to especially acknowledge the pioneering work of Shaji Kumar and his team in basically developing the first monotherapy studies, and they're summarized here with a rapid dose escalation of this generally very well-tolerated oral agent. And this is the remarkable results. If you look at 11-14 positive patients, the response rate to monotherapy is striking in the relapsed refractory setting at around 40%. If, of course, you're non-11-14, these are much more modest. But having said that, the signal is very striking and profound. And this is further exemplified on this particular graphic, illustrating the relationship to gene expression ratios, in particular high BCL2 versus low. So the conclusion from this particular study, the 13367 trial, was that there was successful dose escalation on the one hand, and on the other hand, the response rates were very encouraging and promised further study. This next trial was to look at this approach in T11-14 patients only in the 13367 trial. And again, in the interest of time, I'm going to move through it very quickly, but suffice to say, when you put Venetoclax with dexamethasone in this population, there was very encouraging results with an overall response rate of 65% in a refractory group of patients. So this was particularly important. And I personally was very struck by the VGPR rate of 30%. And you can see here that these responses proved durable with encouraging PFS as well as excellent tolerability. So to me, what is the sort of pièce de la résistance here is actually the combination with bortezomib. And this work has been led by Philippe Moreau. And what you can see here is the design of the trial, the combination approach with bortezomib and dexamethasone in a relapsed refractory population. But importantly in this trial, these were in patients who had had one or more prior therapies, so a relatively earlier group of patients than I showed you before. This is the schema of the treatment plan, and in that context, these are the patient characteristics. A very large study, 66 patients strong. And again, the number of lines of prior therapy were median of 3, so an earlier population, but I do bring your attention to the range, 1 to 13. And of course, the patients were heavily exposed to previous backbone therapies in the setting of novel agents, including, of course, IMiDs and proteasome inhibition. So what were the objective responses? Well, you can see them here. They're really very encouraging in my view. Overall response rate of 67% in patients PR or better for all of them. But if you look at the bortezomib non-refractory or 1 to 3 prior treatment group, striking in the relapse setting at almost 100%. So a remarkable spectrum of activity from the addition of this oral and generally well-tolerated agent. Now, Suzanne did a beautiful work of risk assessment previously in her presentation. I just make the point that in relatively small numbers of patients, because one has to be careful here, we nonetheless see that overall response rate was similar across all cytogenetic abnormalities. And as you can see, these responses were also durable, which is exciting. So the conclusions of the combination of Venetoclax with bortezomib and dexamethasone, I think, are very promising, with high response rates and also at the same time excellent durability of response, particularly impressed by the early use of the drug, and at the same time that this is also active, however, in not just patients with 11-14, but those who do not. So I think this is an extraordinarily interesting and promising platform, and to that end, phase 3 trials are now underway. Now, what about Selinexor? Well, this is a first-in-class, entirely novel drug that's a selective inhibitor of nuclear export proteins and has had a very interesting course. What I wanted to show you first and foremost was work led by Dan Vogel, which was looking essentially at the combination of Selinexor with other agents, and drilled down specifically on various aspects of that study. The mechanism of action is summarized here, but suffice to say, with this inhibition of nuclear export protein and then the impact that this has on key tumor suppressor proteins, as well as other novel receptors, this constitutes a true first-in-class molecule, orally administered, that appears in particular in the presence of other drugs such as dexamethasone and others to have potent effects in terms of anti-myeloma activity. And basically, in the first in-human phase 1 study, Selinexor combined with dexamethasone generated about a 30% response rate in highly refractory patients. Now, STORM has been a phase 2 extension of that phase 1 work. These were highly refractory, truly penta-refractory patients Under the leadership of my colleague Andrew Yee, we at Dana-Farber have participated in this trial and really been impressed actually in these highly refractory patients of what we've seen. I'll go through it here. The Selinexor dose modifications are important to note because dose with this drug and schedule has mattered in terms of tolerability. But suffice to say, with being flexible around dose and schedule, patients can in fact manage to be tailored to dose and schedule that can actually suit them well. So looking at this data, just to give you the numbers, and as presented at ASH in December, if you look at the quad refractory and penta-refractory groups of patients in this trial, 48 strong for the quads, 31 for penta-refractory patients. And as you can see, the median number of prior therapies is impressive. So this is a highly resistant group of folks. What you see that I think is so interesting is if you look at an IRC-mediated assessment of efficacy, what you can see is overall response rates that are encouraging, particularly in such a sick population. And very importantly, if you look at various groups, this is a consistent signal, suggesting that there may be real benefit here. Not only that, if you look at cytogenetics, you can see the same sort of pattern of impact across risk, and these appear durable amongst responders. So recognizing this is a very difficult patient population to treat, and the data here I think are quite impressive as summarized here. And as you can see, for those who actually respond and enjoy minimum response or better, which in the phase 1 space we've always felt matters, you can see real clinical benefit. So the conclusions here are that this is a promising agent, and whilst the overall response rate for Seli plus Dex remains overall modest at around 20% or so, if you look at the nature of these patients, the platform for combination strategies going forward would appear to be very reasonable and rational to do. Now, in terms of adverse events, fatigue, gastrointestinal toxicities, and to some extent suppression of counts matter. What's been very interesting, however, is the success of combining Selinexor with bortezomib. And particularly want to acknowledge the work of Nizar Balis and his team in the STOMP study, which has been the combination of Selinexor and bortezomib with dexamethasone in one particular group of patients. There have been other groups of combinations also explored as part of this trial. But in the interest of time, I'm going to focus on this. This is Selinexor dose escalated between 60 and 100 milligrams, either twice a week or once a week at the higher doses. And there are 42 patients presented here, in whom 40 are response evaluable. As you can see from this waterfall plot, the results are really quite impressive. And indeed, 38 out of the 40 patients evaluable have had reductions in their M protein. So I think this is actually very promising, with quality responses seen. And I think what's particularly important in this group of patients is that the tolerability profile, interestingly, with the proteasome inhibition and steroid in the mix, has been actually better than expected. And I think that's quite something. So this particular approach allows you to dose bortezomib weekly, and at the same time, if Selinexor is given once a week at 100 milligrams, that appears to be well tolerated. And this is the very rational platform for a very important phase 3 Boston trial, which is examining Seli plus bortezomib dex versus bortezomib dex as part of a phase 3 trial. Now, in terms of other key targets in myeloma, I want to just spend a few minutes on targeting protein degradation. This has obviously been absolutely critical. Obviously, we're very familiar with this diagram, recognizing the vital nature of the proteasome in myeloma biology, and that we're blessed with a number of very promising and exciting agents to target it. Of course, the first-in-class bortezomib, we now have the real impact of the remarkable results from carfilzomib. We have in that same space now a next-generation boronate peptide that's oral, ixazomib, which obviously has great tolerability and particularly attractive in older patients. Marizumab is a different proteasome inhibitor that has seen less of the light of day, but we're hoping for much more excitement coming up in the future, not least of which because it's the most potent. It's a beta-lactone, which irreversibly binds beta-5, beta-1, and beta-2, but also because it actually penetrates the central nervous system. And there have been some very interesting case reports of CNS myeloma being successfully treated with it, as well as increasing data, interestingly enough, in glioblastoma multiforme. Having said all of that, we hope to very much bring it back into the myeloma space with force, because, again, combination strategies have been very promising. Interestingly, upstream, another small molecule class, the DUBs, have been of particular interest preclinically. One word of caution, however, the phase 1 trial that was pioneering these, in which we were partnered with my colleague Ola Landgren at Memorial had to be stopped for toxicity. And I would say that one challenge we're seeing in phase 1 development in myeloma now is the caution around tolerability profiles, because we're seeing lots of active drugs, but we've got to be very careful about toxicity profiles. And I guess that's no better exemplified than the experience with the checkpoint inhibitors as well. So moving on, what about other small molecules? So I want to touch briefly on one that's a sort of, I think, a very interesting new approach. This is a peptidase active alkylating moiety that essentially enhances an alkylating payload by targeting myeloma through its peptidase-enriched environment. So just to walk you through this, Melflufen is essentially a derivative of the original Melflufen, but designed to be more myeloma-specific and less toxic to the microenvironment around it, or to the stromal microenvironment in particular. And basically, these amino-peptidases, are highly overexpressed in myeloma, and Melflufen, with its hydrophilic alkylating moieties, binds directly to the DNA through this mechanism. And as a result of these interactions, you see enhanced killing with selectivity in that same process. So walking around the diagram, lipophilic Melflufen rapidly traverses into the cell. Aminopeptidase potentiated release of hydrophilic alkylating moieties occur, and the hydrophilic alkylating moieties are trapped inside the cell. And this results in more cell kill, but sparing everything around it. So there are a number of very important properties, and I want to especially acknowledge my colleague Dr. Dharminder Chauhan, who at the laboratory level has teased these out. And they're summarized here, with an approximately 50-fold higher intracellular exposure, 50-fold higher anti-myeloma potency preclinically, and as a result of that, potent effects on DNA repair with anti-angiogenic properties as well, but critically, this therapeutic index that exploits the fact that there's a difference between it and peripheral mononuclear cells. Very quickly, I'll move through this fast, but suffice to say, relapsed refractory disease has seen a solid response rate from this drug, around 40%, with just Melflufen and Dex combined. Dr. Mary V. Mateus presented the Horizon study at ASH in December of last year. I'll move through it very quickly. It's one of her patients, a pentarefractory patient, had had all the novel therapies, and in fact, it was in real trouble and had actually been through transplantation and a variety of other strategies summarized here. And this patient enjoyed a VGPR to Melflufen Dex as part of this trial. The overall results are summarized here in a waterfall plot. Again, highly refractory patients. And the swimmer's lane plot shows that these responses are durable. And this is just Melflufen Dex. The tolerability is indeed hematopoietic, but nothing else. No mucositis, and the remainder of the features are very benign. So this is actually, I think, a very encouraging approach, and obviously combination strategies are going forward. Now, I want to finish in the last couple of minutes on restoring anti-myeloma immunity. We're obviously going to hear in a moment from Ed about monoclonal antibodies and various other strategies, including cellular therapy. But just to remember the IMiDs, because they're so important. Move through it very quickly. IRF is a key target. We know that. IMiDs target that. So is c-MYC. IMiDs target it. And in that same context, we now have a much better understanding of the pathway through cereblon through which they work. What's critical to know is that beyond, and I'll move through these really fast, beyond this whole platform, we've come to recognize the interactions are so critical and that more potent effects from IMiDs may be vital. So in that spirit, I just want to bring your attention to two new IMiDs that are in the pipeline, and I apologize for the typos. This should be CC9220 and CC92480. But suffice to say, these are very potent IMiDs. Dr. Sagalonial is leading the work with 220, and there's a phase 1 group that it's a privilege to be part of with 480, where we're just starting. And these drugs appear incredibly active in this setting and are going to be, I think, exciting platforms for the future. To sort of emphasize that point, recent studies with pomalidomide have continued to, in fact, in my view, emphasize the platform of combinations that can be very active, including with monoclonal antibodies, including with other next-generation small molecules, a very safe backbone to go forward with. So our expectation is that with these new IMiDs, 220 and 480, we'll see yet another move up the tree, as it were, in terms of benefit. So my concluding comments are really summarized here. They are as follows, really, that obviously we have wonderful backbone drugs, including carfilzomib, ixazomib, bortezomib, lenalidomide, pomalidomide, and so forth. And we have emerging other agents. Of course, we have panabinostat already approved, hopefully next generation HDACs to follow. And now, of course, and you'll hear from this in a moment from Ed, the antibodies, which have completely changed things. We have to be careful, however, because checkpoint inhibition, for example, has been very promising, but yet we need to be thoughtful about our clinical trials that exploit it. I especially want to emphasize the impact of the antibodies, but you'll again hear more from Ed about that. But also to emphasize that the small molecule space is very attractive. And in that small molecule space, we have what I just alluded to with obviously Venetoclax, Melflufen, and Selinexor, but I do also want to emphasize other small molecules that are in the pipeline. And thank you very much for your attention.